it's not easy. It's like, whoa, it's a lifetime of becoming an expert in this. You can't be good at it unless you're looking at your own trauma. You're looking at like how you interact with the world. You're examining like your own lifestyle, and you have your own meditation practice or whatever it is. You have to really learn how to help someone metabolize trauma in a way that's I don't think you can fake it.
Hello, friends. I've missed you. I hope you're all taking care of yourselves out there, giving yourself and all of your relationships a lot of spaciousness and kindness. I know I've needed that recently. I've been facing some pretty big waves and working hard to try to find my through line through all of that. And I really feel that all around us right now. There's definitely a current of people seeking better situations, better health, better jobs that aren't making them crazy and feeling like they're selling their souls every day, better relationships. There's a huge need that goes along with that to address the trauma that is all around us. Like, all of us have been touched by that in some way, from our childhoods right on up through the current culture that we live in. If you live in the United States, certainly, or pretty much in the West at all, we're all carrying the traumas of being part of colonizer culture and being denied access to our ancestors and to the connection to Creator that's our birthright as humans. And not to mention the people that experience micro and macro aggressions every day because they're marginalized, specifically within this culture. I don't think it's surprising at all that people right now are looking to expand the definition of medicine in their lives. I use that word to talk about plant medicine. I know some people don't like to, but that's because it has very directly healed me. Plants like cannabis and ayahuasca and mushrooms, not technically a plant, but I talk about music as medicine too. Food is absolutely medicine. And this conversation is such an exciting one to have in that context because it's about MDMA as medicine. MAPS, the Multidisciplinary Association for Psychedelic Studies, which is really the biggest, most well-funded body for conducting psychedelic research for the benefits of medicalization and legalization. You may have heard it's been in the news recently as part of this tide of legalization of psychedelics. So this conversation is with Dr. Hannah McLane. She's a physician and a psychotherapist based in Philadelphia, and she has been training with MAPS to become a MDMA therapy clinician. And she has founded this incredible nonprofit called the SoundMind Project in Philadelphia. Just before we met at New Year's, she'd actually just signed a lease to open the SoundMind Center, which is poised to become the first FDA-approved, legalized MDMA therapy treatment clinic. So she's put together this incredible team to offer really holistic support: therapists, artists, ethicists, social workers, creating a really strong network of healing. But it's all centered around the offering of MDMA as a psychedelic medicine, as a therapy for PTSD, which is beyond exciting. I talk a lot about my belief in decriminalization and access for all democratically to any kind of mind-altering substance. I believe that's our birthright as human beings, to explore our consciousness in any way that we can in this material realm, as long as we are abiding by the same social contract that we would abide in any other circumstance of respecting life and not harming others as we do it. I know alongside that, I've often expressed my concern that the path this country seems to be taking, which is legalization, substance by substance, and also the medicalization of sort of limiting the contexts in which people can legally engage with these substances, that it threatens to continue to marginalize the same people that have always been marginalized by institutions in this country, including the healthcare system. And it will make these psychedelic medicines like MDMA, psilocybin, cannabis available to mostly wealthy white people, the same people that have access to cutting edge technologies across the boards in this country. And at the same time, millions of brown people will languish in prison on drug offenses, many of them, while the white investors into these psychedelic medicines continue to get richer. So that's a really concerning approach to psychedelic medicine. It is not a psychedelic approach to psychedelic medicine. And talking to Dr. Hannah just radically reassured, opened my mind, and inspired me to what this medicine can do through legal, clinical, medicalized paths. She is so incredibly intelligent and ethical in the way that she is approaching this work. I think she is making sure that it is as accessible and safe and understood as possible, and being really intentional about how it's offered and to whom and when. She is really embodying this medicine. She's an incredible force. I think her path is undeniable. She and the universe are definitely on the same team. So the potential for this medicine to heal people on an individual basis is enormous. And she does a great job in this conversation describing what these sessions look like. But I think in an even bigger picture, she's tackling the very systems that create the marginalization that makes us separate from each other and makes us inflict and experience trauma in the way that we are at the scale that we are right now. That's amazing, because that's actually about change. And that's what healing is. Healing isn't a medication that you have to take every day. Healing means that you get to the oozy, bloody heart of the matter and shine so much love on it that that wound then becomes a gift that you blast out into the world and show people how to walk with and how to walk through. I don't think it's possible to make long-term healing change in the world without this kind of holistic approach. And I'm just blown away with how Hannah holds all of that. That is really the jumping off point for this conversation, and why people who are experiencing it and working with it truly feel like it is a miracle for really desperate people and really desperate times. This is the voice of medicine. There is so much good work being done. Dr. Hannah, I am such a fan. I'm really glad you're here.
I think, first of all, it's important to note that if someone has PTSD, they are already in some way marginalized, right? But then there's all these, like, the people talk about intersectionality, that there's all these different overlapping identities that can create even more marginalization. So for us at SoundMind Center, we're working on specifically people that are marginalized in identity in addition to PTSD. And so we're in West Philadelphia, 75% Black. There's a huge LGBTQ population, high trans population. So lots of groups that have historically faced more PTSD than other groups. So we're working hard to figure out what the barriers are to entry into a treatment for those populations. So it's different for each population. For Black people in this country, obviously, there's the whole history of the war on drugs, and they have been specifically targeted in a way that makes this very scary often. And so even just like showing up at a space that's like psychedelic medicine community meeting, there's a legitimate fear that if there's anything going on that's not legal, I'm going to be the one to get in trouble, you know? And I think that there's just a lot more caution about just engaging in this space. And then in terms of like therapists, there's a lot of, to get trained in psychedelic medicine, it's like we don't know exactly where it's going. Like psilocybin's on its way at some point. MDMA is in phase 3 trials, but it's not guaranteed. There's a lot of unknowns. So you have to have a certain amount of like financial cushion to be like, oh, I'm going to take a week off and get trained in a thing that may or may not happen, that, you know, does cost some amount of financial resources. MAPS does have scholarships for certain groups, but it's a lot to find the resources, to have the time. And then also for Black people in this country, it's like they might not have the same like reaction from their family about like, if I go to my family who's white in New Hampshire and say like, oh, I'm going to be prescribing MDMA, legally. They're like, that's so cool. You know, there's like this whole history of like, whoa, I was in the 60s and that seems great. I have a friend who's a psychiatrist that I wanted to join our team, and he was like, as a Black man, I am already feeling like very ethically, I'm really questioning my choices to become a psychiatrist because it feels so close to like the thing I vowed not to do as a child. I'd like look across the street and see drug dealers and I'm like, I'm never going to be like them. But yet here I am as a psychiatrist and I kind of feel like a drug dealer already. And now you're asking me to actually prescribe MDMA or like psilocybin. Like, well, no, what? My family would kill me, right? That's a barrier. And then just as patients enrolling, it's like there's so many steps that someone has to go through to get to your door, right? Like someone has to, first of all, be able to identify the fact that what they're experiencing is PTSD. Like, not everyone knows what the symptoms are. It can become normalized in populations that have a really high rate of trauma, and they don't even know that there's a diagnosis behind it. There is a valid skepticism towards the medical community, and especially research, with the history of, like, the Tuskegee syphilis trials, in which... I know this has been talked about a lot recently in terms of ethics, but for people that don't know, it went from like the 1930s to the 60s maybe that they had a treatment for syphilis midway through this experiment, and they let Black men who had syphilis slowly die from the disease just to watch it happen and didn't treat them. So there have been some serious ethical violations in this country. I think in other countries, it's like there's a little bit less of this, like, all these steps you have to go through to do human research. And people in the United States think like, well, we really have it down because we have all of these protocols and IRBs you have to get through to allow you to research with humans. But it's also that we have specifically a really bad track record. So when I first got into the psychedelic space, I was thinking, well, you know, maybe we get it approved and then we try and bring in people once it's not in research, because there's all these like reasons why it's hard to think about convincing someone to join a research trial. But then there's other ethical issues involved with that, which is like, say you don't have any of a certain group. If you have no Black people in your trial, then you don't actually know that the treatment works on them, right? And that's what happens a lot. It's like certain groups aren't even represented in the research, and then the drug gets approved and you can prescribe it to them, and you don't actually truly know that the biology isn't slightly different and that they might have a different safety profile, or maybe it's more safe for them, or, you know. So that's a problem. And also just like the types of trauma that different groups face will be slightly different. So you want to have as much of a representation of various types of trauma when you do the trial, to make sure you're including people and you're developing the protocol accordingly. But then there's also the issue of like there's ripple effects, right? If people get in early and there's like therapists that represent different groups, then you have a whole group of people that then can have access earlier on. And if you leave out those groups at the beginning, then they won't necessarily hear about it. And then there will be all these, you know, maybe it's 10 years later that they actually have the access that other groups had. And if they have a higher burden of PTSD, it seems really not okay. PTSD can really hold people back. And this is a treatment that has an incredible efficacy so far. It's like you can't really say it definitely works until you finish all the trials. It's in phase 3.
Could you describe that a little bit, like what it looks like in a therapeutic setting and what you're seeing?
Yeah, so they finished MAPS finished phase 2 trials, and the numbers look like, so just in terms of who gets treated and no longer meets their criteria for PTSD. So they enrolled 107 people. The treatment is 3 months long. What's amazing about this treatment is that you basically take people off most of their psychiatric meds, and then you treat them for 3 months, and a lot of them never have to go back on it. Wow. Which you can imagine that like big pharma may not be that pumped because they make a lot of money off your daily psychiatric meds. But so basically you do 2 to 3 MDMA sessions, which are 8 hours long. And in between each of those 3 sessions, you do shorter 90-minute sessions. So it totals with the 90-minute plus the 8-hour sessions, it totals about 50 hours of treatment. And the 8-hour sessions are the ones you give MDMA for, and you have 2 clinicians sitting with you, and basically the MDMA is given in the morning, and then the patient is basically not everyone knows that like they're there for getting treated for trauma, so you're not necessarily blind to the fact that this is what we're treating, but there is no direction in terms of how you get to the trauma and what you're going to talk about. So it's very formless. It's more psychodynamic approach for anyone who might know about different types of psychotherapies. So basically the patient or the client is the one who is leading the way. And oftentimes they'll spend at least half the time in the 8 hours with eye shades on and like with headphones on, listening to music. So there's like an 8-hour like playlist that they can listen to. And it often looks like they'll put on headphones and eye shades, lean back on a bed, and just sort of like in the treatment that they call it go inside, like you can go inside and see what you find, and they would come out and then sort of talk about the thoughts and memories they're having. And it's really incredible. So the training that I went to last spring with MAPS, they've trained about 250 people, or expanded access, which is a way of offering this therapy to people, which is the same as a phase 3 trial, but it's not actually research. It's it's petitioning the FDA to say, hey, this is so effective. Would we be able to see more patients other than just the people that are enrolled in the trial? Because it's so effective. It's been designated a breakthrough therapy, in fact, by the FDA. So we're all getting trained to do that in addition to the phase 3. Other clinicians are working on that. So at the training I was at, it's like therapists and doctors from all different backgrounds. So social workers, family therapists, MDs, psychologists, and you realize how much people are looking for something that works, right? It's like we have so much trauma and nothing really works. And the things that do kind of work, like prolonged exposure therapy, are just like so uncomfortable to administer and to receive. It's just
What is that therapy?
So prolonged exposure therapy is basically you are asking a person to recount their trauma from the beginning to end over and over again. It's sort of like exposure to the memory. And it's like, if in a lot of ways, MDMA is like a spontaneous prolonged exposure. Like people end up coming out with piecing together the trauma. But it's like the MDMA, the medication basically lets the person not feel so uncomfortable through it. In prolonged exposure, there's like up to a 40% dropout rate. So it's like, it's not comfortable. And even, most people don't make it. And if they do, it's not great. But the MDMA trials so far have been treatment-resistant PTSD. So everyone in phase 2 was treatment-resistant. So they'd already gone through at least one or more other treatments. And it was a really low dropout rate. I think it was around like less than 10%, maybe even like 7%. I can look it up for you. But out of these 107 people, 2/3 of the people after these 3 months of treatment no longer met criteria for PTSD, which is like insane. So it will be interesting to see if those numbers stay the same for phase 3. But if they do, it's like the most amazing numbers. And the fact that people are going off their meds and it's like a time-limited treatment. I think what's most innovative about psychedelics is like we're talking about big doses that actually get to the root of the problem.
It's actually a cure. It's not just a Band-Aid.
Right.
Yeah.
Although MAPS wants to make sure no one uses the word cure until after the... Okay. And it actually, even after the phase 3 trial, it's like hard saying that you can cure PTSD. It's like you can reduce the symptoms. Whether or not it's like cured, it's hard to define, right? It's because everyone will probably still have some residual. But it's like it creates an ability to then function, move forward in your life. And I think that's the big reason why getting this therapy to marginalized groups is so important, because if you're someone that like has had, there's structural bias and structural racism in this country and all these other barriers to like economic stability, and there's a history, you know, sometimes families are less supportive or whatever is going on. There's so many barriers, but then if a person then cannot sleep and they're having nightmares and they're having like flashbacks, and if someone can't go in crowds, it's like it's really hard to just move forward with your life. Mm-hmm. And it's like that's why we need to address the populations that are most marginalized first. Mm-hmm. And it's also a really big challenge because like in the trials, each patient costs MAPS around like $30,000 to treat.
Wow.
So it's not nothing. It's like 50 hours and it's 2 therapists. The therapists for those 3 months are available to the patient 24/7. Wow. So you can call, like you would be able to call me in the middle of the night and I'd say like, you know, what's going on? Mm-hmm. So it's a lot of hours. And then the cost of the medication, the cost of the space, there's, you know, a lot.
Have you been seeing patients in that way through a 3-month
Nope.
period?
So the expanded access is not approved yet. It's basically going back and forth with the FDA. MAPS is the last holdout is that the FDA is trying to require that there will be either an MD or a PhD person on the therapy team at all times, and MAPS is really interested in trying to make it not so high education required, because that will essentially make the treatment a lot more expensive. So ideally you'd have people that could, you know, 2 therapists that could be like master's degree trained, and then you'd always have to have an MD on board to prescribe, but it would be a lot more cost effective if the MD didn't have to be in the room for those 50 hours. Mm-hmm. So there's negotiations going back and forth with them. And we will be likely one of the first in the country to open our doors for expanded access once it gets approved, which is really exciting. Yeah.
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 So when people are under the medicine and they're going through these traumatic memories, as far as you can tell, like what is happening? Are people able to sort of rewrite the memories, or they're negotiating them in a way differently than they usually do when they're being triggered?
Right. I think so. There's a lot of different explanations for why we think MDMA works. So I have a background in neurology, and I feel like most people would expect me to give you the amygdala description, you know, that there's like a fear center, that we're reducing the fear. I actually think that what neurology taught me is that we don't know that much about how the brain and the mind intersect, and it actually makes way more sense to go by what we're experiencing when we're on these medications to understand like how they're working. There's a lot of increased relational aspects that happen when somebody's on MDMA. So I would say that I am a relational therapist. It's a whole type of therapy that will, I guess, argue that all of the therapeutic benefit comes somehow from the relationship between the therapist and the patient. Mm-hmm. So if MDMA creates this ability for someone to trust the relationship faster and more deeply, they're able to then engage in the memory of the trauma in a less scary way. When a stimuli occurs that a person cannot fully process, that is what causes trauma. It's like it's too much to process. And so in a person's memory, when there is PTSD, it often gets jumbled. It's sort of the mind's way of trying to get it to go away or not affect you. It kind of pushes it into this like unconscious place, so that a lot of times people walking around with PTSD, they'll experience the symptoms, but they might not even remember the trauma. Like it can be so deep that it's not even accessible in daily life. So they might have things like safety behaviors. So they might walk into a restaurant and like choose the seat that faces the door, so there's no one that's walking in behind them. You know, there's a lot of like safety behaviors people can do all day, and, you know, have difficulty sleeping or have like hyperarousal, so just like feel like on edge all the time, but not necessarily even know what the main thing is that's caused it. And so a lot of times the fact that the memory is all jumbled is actually what creates the ongoing stress of it. So it's been found in a lot of the therapies. Actually, I think most of the trauma therapies, it's all about piecing together chronologically what happened and really like feeling the feelings that you couldn't feel then. So like prolonged exposure therapy will have you start from like before the trauma started and then after it ended and try to piece together in between and go over and over that until it makes sense. And it's not even clear to people how jumbled it is until they start trying to recount it, in fact. But piecing it together is therapeutic on its own. It's just like, how do you get someone to the place that they can feel comfortable piecing it together? But then once you've pieced it together, you essentially have this like rewriting of the memory that includes a safe person in it. So it becomes less frightening and it will affect a person less.
I would imagine they're less alone with it and less shame too.
Right.
Yeah.
And I think in trauma therapy, it's interesting because the steps that really have to happen to have someone not be so affected by the trauma is like going back, remembering it, feeling the feelings, piecing it together. Oftentimes there's shame and guilt. Almost always there's some sort of shame and guilt that's like, it was my fault. I shouldn't have been there. I should have, not talked to that person. I should have not froze when it was happening. There's just so much self-blame and doubt and shame. So then going into that shame, and oftentimes people will then realize, maybe there were parts of me that could have changed it. And also it's like, that's the only way I could have done it, figuring out self-forgiveness and that there's like many different parts of you that have different feelings towards what happened. It's like all of these, holding those simultaneously together that like maybe, I wanted it to happen and also I didn't want it to happen and I wanted to run and I wanted to stay and I was frozen for a reason because it was so overwhelming. There's all these things that happen and then it becomes less like suppressed and less of this monster that sort of grows in the dark. I think that's what Freud said about trauma. So when I heard about MDMA, it's like, how on earth would you get through that in like 2 or 3 8-hour sessions when it usually takes years and years to get through that in like psychodynamic therapy and then like at least many months and many more hours in prolonged exposure therapy. And it's like not even that uncomfortable, impossible, But when you see people on MDMA, they're getting MDMA therapy, they actually go through all those steps. It's like it doesn't feel like it's missing anything. So
it's just really efficient work.
Yeah. Wow. So it's amazing. And I think that's why, I think out of all the psychedelics, Rick Doblin was talking about why he picked MDMA as the first thing to introduce. And one is that it's like pretty easy to dose because it's made in a lab. If you were doing like psilocybin or a plant-based medicine, it's harder to, it matters like what the soil quality was and the sun. And then this is like in a lab. You can dose it. It's also pretty predictable. It's like people have, they go through this, like, in the first hour, they might feel like really nervous and panicky, but it's like predictable. You can talk someone through it. And also he explains that he feels like therapists would be less nervous to try it. And part of psychedelic therapy and the community is like, actually, if you're giving people these things, you should have tried it yourself. And so in an addendum to the phase 3 trials for patients with PTSD, MAPS has a healthy therapist study running that the therapists they're training to administer the MDMA get first dibs on being a patient. So you basically get treated in just one session with the medication, with the MDMA, just to be able to then talk someone through it. I think that's true. I think if you were like starting with LSD, most therapists would be like, what? Like, I don't want to be in that study. Yeah. But you say MDMA and people are like, where do I sign?
That's so true. Yeah, isn't it? I feel like it has a reputation to be like less scary somehow, or like more of the love vibe. And So how do you see your role as the clinician in the room with people?
I mean, I guess in most psychedelic therapies, you're just acting as sort of a guide, like helping them figure out moving themselves forward. And it's less like telling someone where to go and just being like a safe presence, I think. think in a lot of ways it feels so inspiring as practitioners to have this goal of like being a really good therapist in this modality. Is like it's not easy. And I'm not saying that I'm any sort of expert, and I think that's what's amazing about it. It's like, whoa, it's a lifetime of becoming an expert in this, but it's like a really amazing goal. And it's something that like you can't be good at it unless you're looking at your own yourself, you're looking at your own trauma, you're looking at like how you interact with the world, you're examining like your own lifestyle, and you have your own meditation practice or whatever it is. You have to really learn how to help someone metabolize trauma in a way that's I don't think you can fake it, Mm-hmm. And I think most of medicine you can just like do a fine job and be like totally unhealthy and not sleeping and not necessarily examining yourself. Like, I would say most surgeons probably have a lot of trauma that they haven't dealt with, and they can still take out your appendix and it's fine, But that there's something to strive for that seems like a goal that is worthy. You just see how many people. So even in West Philly, setting up this clinic, I've had 50 people, a lot of them are therapists, reaching out to say they want to volunteer or help, do anything to help make this happen, and that this is what they want to do. And it's like, what is going on outside of this that makes everyone like looking so much for something inspiring? I think there's not that much that feels this incredible and efficacious, and also just like a worthy goal to strive towards.
Mm-hmm. So have psychedelics been a big part of your personal journey?
I guess I would say in high school, I didn't have any idea what, I guess the therapeutic benefits were. Like I was like going to fish shows when I was like 15, and I was like, cool. I think that launched me into a whole meditation life that wouldn't have happened outside of like, those experiences. I ended up doing like maybe like 10-day silent retreats over the course of like high school, college, and after. During med school, I actually, so I went to Brown Medical School, which is like known as kind of a hippie school. And I was like, I would like to go to Nepal and like do a 1-month silent retreat about the medicine Buddha during my first year summer vacation. And they were like, what? And they were like, you, we're a hippie school, but that's a little too much, Hannah. And I ended up like writing a 30-page proposal that was like, I need to study the medicine Buddha. So I went and I like hung out with monks in Kopan Monastery in Nepal. I think for a while I thought like, oh, psychedelics are like the lazy person's way of getting at a meditation experience. And that was like also my young mind, that they're... there's a place for them. I think set and setting is something that in the psychedelic like medical movement that's happening now, there's just a lot of talk about set and setting. It's like the setting has to be a certain way and has to be comfortable. It's like taking mushrooms and going to a party is not going to do the same thing as if you're in like a healing environment with a healing person and have an intention of looking into your trauma. Like it's not going to bring up trauma. I mean, it could, but hopefully might not be prepared to deal with it. Yeah. Michael Pollan wrote an article recently that he was saying, asking the question if psychedelics are wasted on the young, like people in their 70s should be, engaging in these therapies. I think it's true. And I think in dying and in palliative care, it's really amazing how I think there's a lot of potential to use these therapies when trauma often comes up when someone's dying, because it's like, it's being suppressed their whole life and then it comes out, and it's like if we could actually help treat it while it's coming out so they can move into the next world in a peaceful way rather than in a traumatized way. It's like I think there's many different times in a life cycle that it can be beneficial.
Do you see a place for non-clinicalized psychedelic experiences as well?
Yeah, I think that for SoundMind Center, we're really clear that we're not doing anything but the legal medical model. And if there are legal ways for our clinicians to get experiences, that's also good. Part of that is being mindful of the fact that like it is a privilege in this country to be able to do psychedelics and not be worried, right? And so we want to be as open to everyone as possible and not make people nervous by talking about like the non-medical uses of psychedelics. That said, I think it's, with the decriminalization movement happening, I even wonder, it's like, will psilocybin become decriminalized before it becomes medicalized? Is that what's happening? It might. It's like, I think there will always be a role for medical, because I think there are many people that wouldn't do it outside of a medical model, just out of fear of like, what am I getting? And like, who is this person? It's like, you get the qualifications of someone. I do think that when I started out working to make this clinic happen, I didn't necessarily think that decriminalizing psychedelics had to be part of a philosophy, but it sort of becomes more clear, I think, over time, that like if you're really advocating for this is beneficial, it's like, how can you really say it's not beneficial in other settings too? But it is important to have, people that are trustworthy being the ones sitting with the person, and it's harder to like navigate all those things, I think, outside of like the medical setting. Also, people don't necessarily know what they're getting if they're getting something on the street. And it's like, does that all of a sudden make it like the cost benefit analysis is a little different, right? Yeah, I definitely think there's a role for sure.
I'd love to ask you about veterans, which is a big part of your work. Yes. Yeah. What are you seeing there?
So, I'm going to start from the beginning with neurology. So when I started neurology, I was really interested in cognition and the mind, and I wanted to be like Oliver Sacks, and didn't really expect neurology to be all stroke. It's like, as a resident, you're seeing like mostly like acute stroke, and it's like, where am I? What's going on? But what was interesting is I started seeing a lot of people would come in with what appeared to be a physical manifestation of a disease, like a stroke or seizure or like a numb leg or a carpal tunnel, something, and end up being actually underlying trauma that was causing it. And I would say maybe at Penn, maybe up to 25% of people that would come in with neurologic illness would actually have underlying PTSD that then once got treated, it goes away, right? I was fascinated by that and was like, well, what are we doing about those people? And ended up on my psychiatry rotation, I ended up talking to a psychiatrist about how I was like, I'm interested in what they call conversion disorder. People come in and they're like having what looks like seizures, and we actually have to put EEGs, like all these wires on their head, and keep them in the hospital for a week to capture the seizures and see like, is their brain really firing in a way that's seizure related, or is it not? And if it's not, it's what we call non-epileptic seizures, or pseudo seizures is what they used to be called. And I was like, that's so fascinating. And then those patients, like more than half of them have childhood sexual abuse. And same goes for like people coming in with various types of like, a numb leg that actually isn't based on any sort of nerve damage or stroke. And then you treat them for trauma and they get better.
So the body is manifesting trauma that's not being dealt with?
Yeah.
Wow.
Yeah. So I was fascinated by that. And the psychiatrist was like, well, so what you're telling me is you're a neurologist who is interested in conversion, which we used to call hysteria, and you want to leave neurology to like investigate that further because people don't seem to be interested in what you're interested in. I was like, yeah. And he's like, well, I have a person that you should read about. I was like, is it someone I can talk to? Are they at Penn? Where are they? And he was like, no. And you just go home and read about Freud. So like, turns out like that was his actual path. He was a neurologist.
Really?
He was interested in hysteria. He left neurology to then go invent psychiatry and psychoanalysis.
So hysteria is that idea, is like nothing physiologically is wrong.
Right. So it's changed names so many times over the years. It's like hard to trace it back to the original articles because it's like it's so stigmatized that they keep trying to like rename it over time. In the last like 150 years, it's like had 10 different names. So neurologists call it conversion. Psychiatrists call it, what do they call it? I mean, you can call it like psychosomatic illness. There's like a lot of different ways you can call it, but it's all because it's like the names then become stigmatized because we like stigmatize it. So I was like, well, not only is trauma everywhere, but it turns out that it's like actually in every medical specialty. It's like you'll see like my friend who's at Harvard in a GI fellowship is like, it's the same thing. It's like, you know, a third of the people come in and they have like stomach issues that then turn out to be, if you treat the trauma, then the stomach issues go away. So no one's talking about it. What's interesting is that those people never get seen as psychiatry. So psychiatrists think that it's sort of doesn't exist anymore. So in my psychoanalytic circles, when I talk about it, they're like, whoa, you saw that many people with conversion? It's like, because they won't go to psychiatry because they're like, until they actually get their trauma treated, it's like, it really feels physical. And if it feels physical, you're not going to go to psychiatrist. You're like, why are you? So in a lot of ways, what I did in neurology was I saw those people and like, we worked on both angles. Like, okay, say it is, you know, something happening in your brain or something happening in your mind and your emotional, so like part of your emotional state. Let's like address both.
Wow.
I had one patient that she had these like freezing episodes that kind of looked like seizures, but they were like not showing up on EEG on the brain scan. And so I treated her with Keppra, which is a pretty like mild anti-epileptic, and they went away. And then it turned out she did have trauma, and she was like, came back in and said like, you know, I know you talked about it could be trauma or it could be seizures. And like, we never know, like, we don't know which one it is, but the Keppra cured it. But I just realized like that could also be placebo, right? It could still be trauma, right? And I was like, exactly, but we're still going to keep you on it because I like can't, you know, sometimes things don't show up on EEG. So I was like, if it's working, it's working. Let's just stick with that. But in the meantime, like, let's talk about the trauma. So a lot of people think of PTSD as like just part of veteran experience. And I think people that aren't veterans that have PTSD feel like a lot of times they're not understood for it being as severe, but trauma can come in many different forms. You know, I think so after World War II is when they started sort of diagnosing PTSD as like a post-war syndrome. And there's a lot in the psychoanalytic literature about it. So that was really the origin of like understanding it as a diagnosis. And then it became clear that like other types of trauma are just as real. It doesn't have to be like a blast injury or some sort of like near-death experience. And in fact, there's a lot of PTSD that happens in healthcare workers because in the diagnostic criteria of PTSD, it can be, you know, life-threatening to you or life-threatening to someone else near you. And so there's a lot of like similar feelings that happen when like someone is in a life-threatening situation. Vets have a really high rate of trauma, and there's suicides every day in this country. And I think the VA is very interested in different ways to address trauma because it's an epidemic that is not easily treated. So there have been, the phase 2 trial did have vets in it, but there haven't been any studies with MDMA in the VA. So I also do research in the VA, and I'm hoping in the coming years that I can be one of the first to get it through the VA. Even if that doesn't happen, I've been finding that people are very receptive to having like new treatments and are very excited. And veterans themselves, I'm part of a Facebook group that has like, 100,000 members that is composed of vets. I'm not a vet, but they let me in because I said I was like interested. But if I did post something like, what have people found effective for PTSD? And there are a lot of people that like are treating themselves outside of the medical context with psychedelics who are vets and are finding benefit. I can't necessarily say that I vouch for doing that way, but it definitely feels like it's a movement that's happening. And So in order to create PTSD in someone, it's like not everyone who has a trauma then gets PTSD.
Really?
It's only like a third of people that have, like people can experience the exact same trauma, and then only certain people will develop PTSD in the coming months. So there is literature about like what determines whether one person will get it and the other person won't. And one thing is that there is often like a history of childhood trauma or some other types of trauma. So it's almost like there's something cumulative about it. And also like different types of personalities have different predilection to developing PTSD, and whether or not there is shame and self-blame can determine like how much it affects someone. So it's like whether or not that's someone's reaction is to, blame themselves can determine it. There's a lot of different things. Currently, the VA mostly uses prolonged exposure therapy to treat trauma. And this MDMA would require MDs who can prescribe the MDMA to come together with psychology departments who are doing the prolonged exposure. And it's almost like it's like, I don't know if that's a barrier. It's like people that haven't worked together now have to like come together and make it happen. Rescheduling a Schedule 1 substance is also a very big thing. So even after the phase 3 trials are done, if they show the same efficacy as a phase 2, and then it can go into the approval process, the FDA then has to like take it as a Schedule 1 substance, which is like what drugs of abuse are considered, and move it down in order to be able to prescribe it, if that makes sense.
Did it just get scooped in with the drug war in the 80s with everything?
Yeah. I mean, so it was actually developed in a lab as a medication originally for like blood pressure or like blood clots, something that was like unrelated. And then therapists started realizing it was helpful in the therapy environment. So a lot of what we know about how to conduct these therapy sessions happened like in the 60s and 70s when they were doing exactly what we're doing now. And then it sort of went underground, and people that were involved in it originally, a lot of them continued to do it just like in a underground, not legally sanctioned way, but they continued to develop the protocol. So it's like we have in terms of data, we have like 107 people in the phase 2 trials, but we have like a good 50 years of people doing it. So I think there's a lot more knowledge than even comes out in the research that we can draw from. But then after it was being used in the psychotherapy context, then people started using it like for parties. And that's when like War on Drugs said, that's fun. That should be illegal.
Yeah. I'm curious what your perspective is from training with MAPS and dealing with the sort of more legal side, if you have a sense of the trajectory. Because clearly as a people's movement, like people are so ready for this. And there's the pharmaceutical company element, like you said, which is maybe a challenge to it. Do you feel like legalization is just like a train that's moving inevitably with all of these things?
You mean legalization in general, or you mean in terms of prescribing?
I guess both. Yeah, I'd be curious how they're different too.
I would say I do believe that it will happen, both the medicalization and probably legalization. I'm not sure how long. I think probably psilocybin being, like magic mushrooms being a plant, might be decriminalized first, and MDMA still seems like made in a lab. I'm not sure. I think you can just see from what is being published like in New York Times and like in very mainstream media, Fox News, people are like very excited about it. I think that if the phase 3 numbers look like the phase 2 numbers, it will definitely be approved. If there may be like a delay in how long each state takes to reschedule it and to then approve it after the phase 3 trial. You never, 100% know what you're going to come out with, but it looks like it's definitely going to happen.
Wow.
Yeah.
Wow. So what are the next steps for you here in Philly?
So we basically have an 8-person team, psychotherapy team, and I'm really excited about the people we have on the team because everyone brings different experiences and expertise to the table. It's been I'm very excited to work with everyone. We just found an office space on 46 and Spruce that will open in a few months. We're basically going to open as a group psychotherapy office that we will also offer ketamine. So ketamine is being used for treatment-resistant depression. And a lot of clinics across the country that are working to open a psychedelic psychotherapy clinic are using that as like the first step because it's already can be used off-label for various things. Also, I think just coming together and creating a cohesive therapy group that we're supporting each other in treating trauma, I think is really important. So we're going to use the time in between when we open and when MDMA is approved for either expanded access or fully approved to build like our clinical model, our therapy model. We've decided on using a sliding scale model for payment. So certain people, if they can pay, will pay like a full fee, and that will help subsidize people who can't pay. We decided to go with the nonprofit route. There are definitely, I've been approached by several investors who want to like throw money at MDMA clinics, partly because I think they imagine that it's like the next cannabis, like people are going to get rich, but they can't really figure out how to capitalize on it, because you can't like sell the MDMA. MAPS has an anti-patent on it, so like no one can patent it. Hopefully MAPS after the anti-patent can own the patent once that's over. It sort of buys them some time to figure that out.
So MAPS is actually producing the medicine?
Mm-hmm. Yeah. They actually have like a store from a while ago. I think it's from like, I don't know if this is like public knowledge, but from like the 60s or 70s that there's like some huge vat that was made that's like just as effective. So they're just going on that. But yeah, they'll be providing the sites MDMA. So basically when we provide it, we'll have like a closet that's like a locked closet in a locked safe that like only I will have the code to, with like security cameras everywhere. It'd be really intense, but it has to be on site. And yeah, I think it's just figuring out the financial model and like, is there a way that we can create like some sort of concierge version that like people will pay even more than the cost to get something extra to then subsidize people who can't pay anything. Like what does that look like? We also we're working on building a satellite location in Puerto Rico. So it'll be like in a natural environment. So Philadelphia has the second largest Puerto Rican population outside of Puerto Rico. Really? And a lot of people came here relocating from Hurricane Maria. And PTSD is a very common reaction to natural disasters. So we have people on our team whose parents are Puerto Rican, and we also have a colleague in Puerto Rico who's training with MAPS. So we're hoping to address that here and there. So that'll be exciting, and I think also may create some opportunities for like meeting people there to offer like a session in the rainforest, and that could potentially be like a concierge model that that subsidizes people that really need the treatment but can't pay anything. So, yeah.
Thank you for making it accessible. That makes me so happy and
we're working on it.
Optimistic. Yeah.
But yeah, I think the challenge will be as it becomes commercialized. Like even though MAPS isn't commercializing the medicine, it will. I just imagine that as things move forward, it will become commercialized.
Yeah.
And figuring out the way that we can own what we're doing and not be pushed into certain directions in terms of what the therapy looks like or how we work with different groups and how profitable each person has to be, each therapy session has to be. I think that's the biggest thing is that we're really working to raise money. So we have nonprofit fundraising activities that we're working on, and we are a 501c3, so people can make tax deductible donations, and also just like creating this model and trying not to accept money from anyone who wants to own something about the some of the investors want to own the protocol you develop, and it's like I don't even know it, or like the clinical data. And it's like I don't think that's ethical, but so it's it's like how fast do you want to start and how much are you willing to give up in the vision. And I think for our group, we don't want to give up any part of the vision.
Amen. Hallelujah.
So, yeah, wish us luck.
Well, maybe for a last question, this is, I guess, a little bit of a two-parter, but it seems like trauma is a continuum, and most people that I know have some amount of trauma.
Right.
Do you feel like MDMA could be for anyone? And also for people that aren't ready to do that, do you have any sort of other tools that you feel like are helpful for starting to deal with trauma?
Yeah, so I think I would say my opinion is that everyone has some amount of trauma. Now they're calling like things that don't fit into PTSD diagnosis, they're calling them like adverse childhood experiences, or I have a strong interest in microaggressions and chronic daily traumas for people that, so people of color or people that have disabilities or people who are LGBTQ, how they're facing like daily invalidations and daily like messages from society that they're not good enough or they should question who they are. I have dyslexia, and that's actually how I sort of got into the area of research that I do about microaggressions and just like, what does it do to you if you have this experience of feeling like, wow, everything is so fucking hard? But yet when you tell someone, like, I have dyslexia, they're like, oh, I don't think of you as dyslexic. It's like, is that a compliment or is it, like, totally invalidating? That, like, it takes me 3 times as long to read everything than this person. So a lot of my understanding of my own experience came from the literature on racial microaggressions. That's mostly what it's been... what's been written about, but it does carry across like different marginalized identities. And that's something that unfortunately doesn't fit into the, like, even if it's cumulative, and there have been research studies that looked at like over time, if someone is treated certain ways every day, there's like, you get higher blood pressure and you get depression and there's like all these effects of it. But if you don't have an index trauma, like one event that you can go back to and say like, that's the thing that caused all my problems, you don't actually fit criteria for PTSD, and therefore we can't even enroll someone that doesn't have PTSD. And that's really sad. And so part of it is like, as clinicians, like, you know, helping someone as much as you can pick the right, you know, the right index trauma that will qualify them, like taking the time to really understand like the various things that have happened to them. And maybe someone with autism that might not have the same reaction to the trauma, but still has it, like helping them express themselves and how it has affected them in different ways. Just like taking extra time to really work with people that may be sort of, you could get to qualify, but maybe you wouldn't if you just did it too quickly, you know? So really being aware that microaggressions and chronic daily traumas are real and do add up to trauma, but that unfortunately the DSM manual that we use in psychiatry for diagnosis doesn't count that. I think that in a lot of ways is a structural bias. It's like institutional racism to say like, sorry, the thing that you experience isn't going to get you qualified to get treated, like means certain people that maybe have, you know, not even as severe of a need will qualify for. It biases who we can enroll. So I think that's a big area of interest for me to help work towards getting that included, getting clinicians to really fully buy into the fact that it is as real as one index trauma, that people that experience like violence every day may not be able to even pick out which one's the worst one, but that matters, that like someone can't identify it, maybe because they have too much. So for those people, I would say, we're working to change that. I think there are a lot of different things that can be done for trauma. You know, some people definitely do go the underground route and find someone who can sit with them while they take MDMA. I would say, personally, I would be a little bit afraid to do that if the person hasn't had a ton of trauma experience. Like if someone has trauma or something that seems almost like a diagnosis of PTSD, it's really important that the person sitting with you has had a lot of experience to know like what is going to come up. But other things like meditation, There's holotropic breath work is something that I think several people on our team are going to get trained in, because that's sort of it's a altered state of consciousness that involves like breathing in certain ways and can create like a similar like bringing up of trauma. So that's another way that it's like not even related to any sort of medicine. And also something that MAPS recommends people to get experience in, because it really helps with the MDMA sessions too. What else to do for trauma? Get a lot of sleep. I think that like sleep is the mediator for a lot of mental health issues, maybe all of them.
Wow, yeah.
So, working on circadian cycles in the winter is really a big deal. Like, as long as you don't have any contraindications to a light box, I would say everyone in our area in like Philly or in the northern part of the world should like wake up and sit in front of a light box for a half hour just to like get sleep cycles in place.
Is there anyone that you would say definitely should not do MDMA?
MDMA? I was going to say a light box. Well, if you have eye issues, if you have migraines, if you have seizures. So there are like exclusion criteria, and a lot of that is like cardiovascular. So if someone has like arrhythmias, like heart issues, then it can be dangerous, because it's like sort of a cousin to amphetamines, in fact. And so it can like increase blood pressure and heart rate, and that can cause complications. And that's one of the main groups that can't get it. But hopefully, as other psychedelics become available, those groups can get other things. So people have to be off certain psychiatric meds for at least a month or so before starting. Partly it's like people that are on serotonin-based psychiatric meds don't get as much of a effect from the MDMA. So part of the reason to take them off it is to make sure they get like the serotonin blast that you kind of need to get the therapeutic effects. Because if not, then you're going to get like this half reaction, and then it's going to be like you'll get all of the anxiety parts and none of the trauma benefits. It's like, that sucks. So my team has a really strong interest in treating addiction with psychedelics, and there are like many research articles that explain how it most likely will work for that. The PTSD treatment studies that MAPS is doing now, like you can't be actively using, but hopefully in the near future we'll be able to enroll people for the purpose of treating addiction. So we're excited about that, but for now we can't enroll people.
God, there's just it feels like so many people could benefit from this. So many different challenges people are facing that I'm so grateful it's becoming available.
Yeah, me too.
Wow.
It's really exciting.
Wow. Well, thank you.
Thank you.
Thank you so much for sharing.
Yo, how rad was that? What a blast of momentum. I can only imagine how life-changing it will be for people to walk in the door to the SoundMind Center and find themselves sitting in front of her. When I was in college, I was having a lot of digestion issues that were making me feel pretty shitty and grumpy. And I went to see a practitioner in the school, health center. And I told her what was going on. And she took some notes, and then she pointed at her head and she said, "We need to fix what's up here before we can fix what's down here." And she pointed at her stomach. And I remember at the time being so pissed. And the way she said it was extremely pejorative. So it was easy for me to be triggered and offended and take it as her basically saying that I was making it up, and that the pain that I was experiencing, I just needed to like change my mind or snap my fingers and see the bright side of life, and it would be all good. And I will say that there were, I changed a lot of my diet after that, that I think made some real physiological differences in how I process food, and I feel much better because of that. And also, yeah, she was definitely right. I was in a really unhealthy period of my life where I was doing a lot of self-sabotaging depressive behaviors that were keeping me feeling very stuck and broken. I just didn't feel well in pretty much every area of my life. And in retrospect, I was like, oh man, she actually saw something, but what a missed opportunity to help me do anything about it. I hadn't thought about that in a long time, and I don't blame this woman in particular. Like, I was one of how many students that didn't have real health insurance shuffling through this university health center that doesn't have a great system for tracking students long term. You know, not her specific problem. Even the fact that she was acknowledging that there was a mind-body connection was probably leagues ahead of what a lot of people experience when they go see their doctors. And it wasn't until I was talking to Hannah that I kind of remembered that and felt so excited about a new wave of practitioners coming into the season of their lives where they're really owning their own practices and doing things the right way and able to follow through on that feeling of like, oh, I think this person maybe has a lot more going on than just this compartmentalized diagnosis that I can throw a pill at, and really helping people blossom on every level where they need healing and meeting them from that spirit. It's not a condescending spirit, it's a walking through this together spirit. I think we can do that in all of our professions. We don't need to be doctors and mental health experts in order to be that presence for ourselves and others. And I want to express my gratitude to so many of you out there who I know help the people that you encounter in the world learn about their options, learn what's available to them, whether that's psychedelics or meditation or getting an exercise routine going. Like, that information that y'all are trading amongst yourselves is the currency of love, and it is part of the transformation of our society that's happening right now. That is the mycelial network of procreation and healing that the universe supports. That's why we're all here, is to remember that we are part of higher consciousness and to trade those little signals with each other. That's the electricity between the neurons that we are, that's going to spark ideas and movements and patterns of social organization that are so much bigger than we are. And it's happening. I know it's happening, and it's because of what you're doing in your own minds and hearts. So if you, like me lately, have been falling into some traps, forgetting your own agency and feeling overwhelmed, I just want to remind you that the steps that you are undertaking in your life right now to feel better are making us all more well and more healed. So thank you. I love you. Please remember to love yourself. The medicine is inside of you. You're not alone.
We stroked our arms and we wore them thin. The sadness, it was there. But you don't miss it, man. You got it all like a memory. Now it's living under your skin. Love's the key to the games that we play. But don't mind losing. Love's the key to the things that you see. But you don't mind moving. It's the door in the dark of the way. It's the key in the dark for the spark. Love's the game all the way the same. Oh,